Hello, and welcome to the Electrolyte Club. My name is Helbert Rondon, and I am a nephrologist at the University of Pittsburgh. This is lecture number 4, Pathophysiology and Etiology of Hypotonic Hyponatremia, Part 2. The learning objectives for this lecture are: number 1, list 3 mechanisms causing hypotonic hyponatremia from decreased renal water excretion. Number 2, explain the pathophysiology of hypotonic hyponatremia due to hypovolemia, heart failure, and cirrhosis. And number 3, describe the key clinical features of hypotonic hyponatremia from hypovolemia, heart failure, and cirrhosis. We're going to start with a case scenario. This is a 19-year-old college student comes to the emergency room with severe diarrhea for 2 days. He tried to keep himself hydrated drinking Gatorade at home. On exam, jugular veins are flat, lungs are clear to auscultation, and there is no peripheral edema. Orthostatic vital signs reveal a supine blood pressure of 100/60 and a heart rate of 94, and upon standing, the blood pressure drops to 70/40 and the heart rate goes up to 130. Labs show a sodium of 130, potassium of 3.1, bicarbonate of 18, urine osmolarity of 413, urine sodium of 15, and urine potassium of 23. So the first question is, what is the state of total body sodium in this patient? Is it A, decrease, B, normal, C, increase, or D, unable to tell based on the information provided? And the right answer is A, decrease. This patient is presenting with hypovolemia or extracellular fluid volume contraction. By definition, total body sodium is decrease. Now, the next question is, what is the most likely cause of hyponatremia in this patient? A, SIADH, B, primary polydipsia, C, decreased effective arterial blood volume, or D, low solute intake? And the correct answer is C, decreased effective arterial blood volume. So, hypotonic hyponatremia, as we review in lecture 3, is always an excess free water problem. Now, how somebody develop excess free water? There are 2 main reasons. One is because this person is drinking too much water to the point that exceeds the maximum renal excretory capacity for water. So increased free water intake. And the other reason is that we're not drinking a lot of water, we're drinking a normal amount, but the kidneys have trouble getting rid of the water, so decreased free water excretion. There are also 3 mechanisms by which the kidneys cannot get rid of water. Number 1 is that there is too much ADH, and this is the main mechanism of hyponatremia overall. Number 2 is that there is a decrease in solute intake, and number 3 is that there is low GFR. Now, high ADH is also caused by 3 different mechanisms, and in this lecture we're going to review one common mechanism, which is low effective arterial blood volume causing hyponatremia. Now, in order for us to do that, we're going to review first what are the 2 physiological stimuli for ADH. We have an osmotic stimuli for ADH and we have a non-osmotic stimuli for ADH. So in the osmotic stimuli for ADH occurs when the plasma tonicity changes. When the plasma tonicity is high, for instance, that's going to stimulate the main central osmoreceptor, which is the OVLT, located in the hypothalamus, which will send signals to the ADH producing neurons in another area of the hypothalamus, and these are the supraoptic nuclei and paraventricular nuclei, and these are going to produce ADH, which will then be traveling down the pituitary stalk into the posterior pituitary, and then it will be released into the circulation. When the plasma tonicity goes down, then we will do the opposite. It will inhibit the OVLT, and therefore there won't be any signaling into these ADH producing neurons, and ADH will not be produced or released into the circulation. So this will inhibit ADH. Now, the non-osmotic stimuli for ADH happens when there is low effective arterial blood volume, which means that the effective blood volume is going to be reduced by more than 15%. That's going to stimulate the baroreceptors, which will then send signals to the medulla oblongata, specifically a structure called NTS, or nucleus of the tractus solitarius, and from here there will be a signaling into the ADH producing neurons in the hypothalamus, which will increase ADH production, and then ADH will be traveling down the posterior pituitary, and then it will be released into the circulation. Now, what happens when these two stimuli, low plasma tonicity and low effective blood volume, are presented at the same time? And this happens in hypovolemic hyponatremia. On one side you have low plasma tonicity from the hyponatremia, and on the other side you have low effective arterial blood volume from hypovolemia. So one inhibits ADH, one stimulates ADH. Which one is stronger? Which one wins? So actually the body always tries to preserve volume. That's their priority, because hypovolemia was going to kill the patient first. So the body is going to respond to low effective blood volume much more stronger, and this stimuli will win and cause ADH to be produced. Now, we can express the same concept in a different way. So in this graph, we're showing on the y-axis plasma vasopressin levels, or plasma ADH, and on the x-axis plasma osmolality. We know that under normal conditions, this line here, plasma osmolarity that is greater than 280 will produce ADH to be secreted, and the greater the osmolarity, the greater the ADH, and that's what is been shown in that blue line there, that it says marked with an N. Now, what happens when you have hypovolemia? Let's say if your effective blood volume drops, and now the curve is going to be displaced to the left. So if effective blood volume drops by 15% or so, now you're also going to release ADH as osmolarity goes, but now the threshold is lower. It's 270 now instead of 280. So even at 275, where under normal conditions there should be no ADH, if your volume depleted, you will still release ADH. And as you see there, the line will be more brisk. There will be more ADH produced. So when you're hypovolemic, the set point for tonicity is shifting to the left. Okay? And some people hypothesize that the reason for this is that when you are hypovolemic, your RAS system is activated, so you have angiotensin II, and angiotensin II is going to sensitize the neurons, the ADH producing neurons, to produce ADH, even if the osmolarity is not more than 280. And that phenomenon is called osmoreceptor gain, and is mediated by angiotensin II. Okay, so what happens in hypovolemic hyponatremia? You have your normal total body sodium, normal total body water, these boxes there, and they are of the same height, meaning that the normal ratio between sodium and water is maintained. So now you're gonna develop hypovolemia, which by definition is ECF volume loss or isotonic fluid loss. It could be due to a bleeding, or it could be due to, let's say, secretory diarrhea, and that's gonna basically create hypovolemia, where you lose sodium and water from your body, but because you're losing isotonic fluid, there is no problems with the normal ratio between sodium and water, and the ratio is maintained normal, so there is no hyponatremia yet there. But if the amount of volume that you have lost is significant, that's going to cause decrease in the effective arterial blood volume, more than 15%, which will activate ADH. And if the patient is drinking water or hypotonic fluids, such as Gatorade, then that's going to make the patient to retain a little bit of water, and the total body water will be greater than the total body sodium. Both will be low, but the water will be greater than the sodium and cause hyponatremia. So one example of this is when you have a patient in your clinic who calls you and said, "Doctor, I'm having diarrhea. What should I do?" And the standard advice is, "Oh, keep yourself hydrated. Drink lots of water." That is actually the wrong advice. The correct advice would say to say to the patient, drink lots of water, but also eat salty foods. Otherwise, you'll get hyponatremic. But if you're eating salt because your RAS system is going to be active, right? You're hypovolemic, you'll retain that salt, and eventually you'll retain isotonic fluid. Another advice would be to tell the patient to drink chicken noodle soup or Campbell soup, has a lot of salt, so that's closer to isotonic fluid as well. All right. Now, what are the key features of hyponatremia from hypovolemia? First of all, because your effective blood volume is reduced, your ADH is activated, your urine osmolarity is going to be higher than 100. Now, because your RAS system is also active, since the patient is volume depleted, the kidneys are going to hold onto sodium, and that will make the urine sodium concentration to be low, less than 20 usually. And clinically, the patient will be hypovolemic, right? As you know, there will be hypotension, tachycardia, flat jugular veins, etc. Now, we have another case scenario here. This is a 48-year-old woman with a past medical history of liver cirrhosis due to hepatitis C, who is admitted for anasarca. Her only medication is furosemide 20 milligrams PO daily. On exam, her blood pressure is 98/56, heart rate is 78, oxygen saturation is 89% on room air. There is no jugular venous distension, but on lung exam, there is no breath sounds on both lung bases. Abdominal exam shows collateral circulation with ascites, and also there is 3+ speeding edema in lower extremities up to the knees. The labs show a sodium of 126, bicarbonate of 19, urine osmolarity of 335, urine sodium of 22, and urine potassium of 34. So the question now is, what is the state of total body sodium in this patient? Is it A, decrease, B, normal, C, increase, or D, unable to tell based on the information provided? And the right answer is increase, right? This patient has hypervolemia, extracellular fluid volume expansion, right? The patient has ascites, edema. So all of that means that the patient's total body sodium is increased. So what is the most likely cause of hyponatremia in this patient? A, SIADH, B, primary polydipsia, C, decreased effective arterial blood volume, or D, low solute intake. And the right answer is C, decreased effective arterial blood volume. So similar to the first case, the only difference is that the volume status of this patient, the ECF volume, is increased and the total body sodium is increased. The first case, total body sodium was decreased, ECF volume status was decreased. But they both have low effective arterial blood volume. So how does this happen? So let's examine what happens in the hyponatremia of heart failure and cirrhosis. And they have a similar mechanism. So initially you have your total body sodium and your total body water, and they are normal and they are maintaining a normal proportion. And then you develop heart failure or splanchnic vasodilatation, which happens in cirrhosis, right? We said vasodilatation and heart failure are other two causes of decreased effective arterial blood volume, right? These two. Early in the disease, when the disease is not too advanced, right? Then what happens is, because of the decreased effective blood volume, the RAS system is going to be activated. And if you have RAS system activation, then that's going to make you retain sodium, and then water is going to follow sodium. So at the end of the day, you will retain sodium and water, or isotonic fluid, and you will develop hypervolemia, right? You will develop edema. But this patient doesn't have hyponatremia yet, not yet. As the disease progresses, as the ejection fraction of the patient with heart failure goes from 45 to 15, or the MEL score in a patient with cirrhosis goes from a MEL score of 10 to a MEL score of 30, so late in the disease, then the effective blood volume is going to go even lower, and now ADH will be activated, right? And if the patient is drinking water or hypotonic fluids, then they will retain a little bit more water than sodium, and that will cause hyponatremia. So when you see hyponatremia in a patient with heart failure or cirrhosis, that means that the disease is pretty advanced. It's late in the disease. There's more neurohormonal activation. Now ADH is activated. It's telling you that the disease is very advanced. So hyponatremia, the presence of hyponatremia in cirrhosis and heart failure, is a marker of mortality, because that means the disease is very advanced. And it has been demonstrated in many studies. So what are the key features of hyponatremia from heart failure and cirrhosis? First of all, you have decreased effective blood volume, and that's going to activate ADH, and therefore the urine osmolarity is going to be high. It's going to be greater than 100. Second, you have a RAS system activation, and your kidneys are holding on to sodium, so the urine sodium will be low, right? And third, the patient's volume status. The ECF volume is expanded. The patient is hypervolemic, so you'll see edema. In heart failure patients, you see JVD, crackles in the lungs, etc. All the stuff that you already know. So what are the take-home points? High ADH, low GFR, and low solute intake are the main mechanisms causing hypotonic hyponatremia due to decreased renal water excretion. Hypovolemia, heart failure, and cirrhosis result in hypotonic hyponatremia by causing decreased effective arterial blood volume and subsequent ADH release. Key clinical features of hypotonic hyponatremia due to hypovolemia are hypovolemia, high urine osmolality, and low urine sodium. Key clinical features of hypotonic hyponatremia due to heart failure and cirrhosis are hypervolemia, high urine osmolality, and low urine sodium. Thank you for your attention.